Assalamu alaikum, everyone. My name is Lema Sibai. I'm a third-year medical student, and today I'm going to be teaching you all alveolar ventilation and pulmonary gas exchange. Now, be cautious. This is kind of a loaded topic, so I'm going to need you to focus with me 100%. Now, fortunately for you guys, when I was a first year, the content was basically the exact same, and Dr. Shams didn't really change anything. So I made notes when I was in first year, and I linked them right over here if you want to use it to keep up with me. It has everything important, has everything high yield, and inshallah, it'll be very beneficial. Okay, so before we talk about alveolar ventilation and all the kind of like microscopic details, we have to talk about the macroscopic details. We kind of have to zoom out and kind of look at what we're kind of like study what we're looking at, right? So the respiratory system, the human respiratory system, let's take a deep breath in, okay? Where did that air just go through, right? Let's talk about that. So it went through my nose and then down to my trachea, and then it goes to the trachea kind of separates and it creates something called bronchi. And bronchi kind of separates further and further and further until it gets to alveoli. And alveoli is basically where all this important um, physiology happens, right? This is the whole point of this entire lecture. And wrapping around the alveoli are these blood vessels or like pulmonary venules. And this is where most of like the gases even get to the lungs. Like this is how the gases get to the lungs, right? Okay, so now that we understand this, I'm going to explain this figure or what I explained last, but in more detail. Okay, so again, let's take a deep breath in. Where did that air just go again? Okay, the air just went down into this alveoli. And this alveoli is just a separate unit. And wrapped around this alveoli, as I said, are pulmonary venules. And what happens is that deoxygenated blood, actually, wait, no, let's start over here. So I'm breathing oxygen in, and this oxygen has to go somewhere, right? So the oxygen diffuses into the pulmonary venules and it goes to the rest of the body, right? As oxygenated blood, which supplied the body and the tissue with the oxygenated blood that they need or the oxygen that they need, right? And so as these cells take in oxygen, what they do is that they're using all this oxygen and like they're doing their cell business or whatever cells do. And what they do is that they get rid of something called CO2. We all know CO2, it's a metabolic waste product. It's just waste from doing work, right? And so CO2 travels with the deoxygenated blood that the cells have left behind, and they get kind of diffuse into the alveoli and they go back up, right? And so when we breathe in, we're breathing in oxygen, and when we breathe out, we're breathing out CO2. And that's just the basics of what happened, the basics. Okay? So let's go into more detail. Alveolar ventilation. What is it? Why do we even need it? Ventilation is simply just the movement of air in and out that actually creates meaningful exchange, right? So when I say meaningful exchange, I mean that, oxygen has gone in and CO2 has gone out. So if I say that I have breathed in oxygen and I'm not releasing any CO2, is that ventilation? Is that even successful ventilation? No, I wouldn't call it ventilation because nothing got ventilated, right? I'm not releasing any CO2, so therefore it's not ventilated. Okay. Okay, we talked about all of the, oxygen exchange and CO2 exchange and whatnot, but how do we exchange oxygen and CO2 like the same way everywhere? Obviously not, right? So it differs from tissue to tissue or different kinds of cells. Okay? So for example, so essentially, respiratory exchange ratio just means that we're calculating the ratio between CO2 output, so how much we're releasing, to oxygen consumption, so how much we're consuming. So, for example, uh, carbohydrates, they consume 6 molecules of CO2 and no, they consume 6 molecules of oxygen and they release 6 molecules of CO2. Um, and what that creates is just a respiratory exchange ratio of 1. All right? Fats, however, have less. So they consume more oxygen and release less CO2. So that creates a ratio that's less than 1. Now, this is important in what context? I'll tell you what context. Like clinically, for example, there's lots of patients in the ICU and they need to be carefully monitored. Their diet needs to be kind of monitored. So what they do, or like what physicians do, is that they calculate the respiratory exchange ratio. Now, if they calculate a respiratory exchange ratio of 1, that means that they're burning carbohydrates, or they're using up carbohydrates. And that's good because they're being well fed, right? And that's like our body's first instinct for like energy. However, if they see that the respiratory exchange ratio is less than 1, then that means they could be malnourished. Now, there's different like factors that play into it, but this is just an example of why this could be beneficial. Because I hate is a strong word, but I don't like studying things without like some sort of purpose. So this is just a fun fact. Yeah, so if physicians see that the respiratory exchange ratio is less than 1, then they'll think, okay, so they're burning fats. And when you burn fats, that's kind of like a last resort for your body to get energy. So they would understand that, okay, this patient is maybe malnourished and we need to look into it. It's kind of a dietary thing. And I don't know, I thought it was interesting. But yeah. Okay. All this is saying is that the respiratory exchange ratio, like what you consume and what you output, like they're both equal. So like what you take into your lungs and what you bring out from your tissue are exactly the same. Like it's the same amount, the same ratio. Okay. Basal metabolic rate. This is really important. So okay. I'm sitting right here now and I'm talking to the screen and I'm not really exerting that much energy or that much force or that much to do anything, right? My heart is still pumping, I'm still breathing, my brain is still functioning. There's a specific amount of oxygen that my body needs, all my cells need to maintain this basal or like kind of like super basic function, right? Or like metabolic functions, right? And this is the basal metabolic rate. It's quite literally what it is. And like generally, it means the minimum oxygen required to maintain vital functions. And the interesting thing about this is that lots of factors affect it. However, we're going to be focusing on temperature. So, as temperature increases in my body, right now I'm sitting here and I'm not doing anything, but my temperature is increased. That's the only difference, right? Let's say I have a fever, for example. I have a fever and my temperature is increased. My body needs more O2. And as it needs more O2, that means the basal metabolic rate has increased, right? It's consuming more O2 and it's, dumping out more CO2. And so the metabolic rate has increased. Like the rate to kind of consume and output has increased. And that's just generally what it means. So increased temperature means increased metabolic rate because increased consumption of O2, increased output of CO2. Okay, so let's say I'm freezing. I'm freezing now. Ugh, I'm so cold. And now I have hypothermia. Now, hypothermia means that the temperature in my body has decreased. All right. Now, a decreased temperature means the basal metabolic rate has decreased. And so my oxygen consumption has decreased and my CO2, what's it called? Like output has decreased. So that's all it means. So increase of temperature, increase of basal metabolic rate, decrease of temperature, decrease of basal metabolic rate. And this sets up like how much ventilation you need, right? I said that as you increase the temperature, you're consuming more oxygen, right? So the ventilation by default needs to increase, right? If you're not getting enough oxygen and releasing enough CO2, then that's not good. It's kind of like proportional. Okay, next concept. Now, this is my basal metabolic rate, right? I'm not doing anything. I'm sitting down. But let's say like I start working out like this guy. Suddenly the suddenly the work and the oxygen required in your body go up proportionally. And like you can work out as much as you want. However, there's a point that you get at. Like there's a point where your body just kind of like exchanges oxygen and CO2, and there's a point where it cannot do more of that. And that's called um, VO2 max, which is just maximum O2 uptake, right? Now, typically in normal adults, this is times 10. So it's what's it called? Tenfold. However, in like athletes who kind of exercise their cardiovascular system daily and kind of have like a solid cardiovascular structure, then it's more. But for me, for example, it's tenfold. Okay, so now we're going to talk about foundations. We talked about like why oxygen is important, how CO2 kind of like counteracts with oxygen in the body, like kind of more general things, but now we're going to talk about how air moves, which is a very big part of alveolar ventilation. So now that I'm breathing in and I'm breathing out, right? There's two zones that make up my respiratory system. There's a conducting zone and there's a respiratory zone. Conducting zone just means all the path, all the paths that oxygen takes to get to my alveoli that doesn't actually like exchange anything. So my nose, my trachea, my bronchioles, I don't have any kind of like exchange system there. So it doesn't work. It's called conducting zone, but it's also called dead space. Now that's kind of morbid, but that's just what it's called. It's called that because nothing actually happens. Just think about it like nothing actually happens, nothing's actually alive. Now respiratory zone is called alveolar zone, obviously, because it's mostly focusing on all the alveoli. Like that's it. That the only like exchange portion of the entire thing. Okay. So we're going to have stay with me because I'm going to be saying like a couple of terms that you need to remember. Now, this is a very simplified diagram of a lung, right? So these are just the lungs, and this is like the alveoli. Now, I'm breathing in. What is this called? Or breathing out, right? Breathing in and breathing out. This is called tidal volume. Now, tidal volume is just the amount that you breathe in and breathe out in one quiet breath. I'm not talking about some going deep into your lungs and like breathing in all the air you could ever breathe. This is just one quiet breath normally while I'm not really thinking about it. This is approximately 500 milliliters, and what's it called? It's called VT. It's like that's just what it stands for. VT stands for tidal volume, right? So what actually happens with this tidal volume? What happens is that when you breathe in, it separates into two zones. Just like we said, it separates into dead space and the alveolar portion, but it has different names, right? So the tidal volume, it's made up of 500. So just imagine that the total of all of this is 500. So there's a portion of it that, pushes into the alveoli, and this is called alveolar volume. There's 350 milliliters of the 500 that we talked about from the tidal volume that does this. Hold on. That does this, right? Only 350, because that's just how much it can take, right? And this is called alveolar volume, and it's called like VA. And there's a portion of it that gets pushed in afterwards, but doesn't actually involve any exchange. A good point is that this involves exchange, like this exchanges gases. So what happens, as I said, it like substitutes its O2 for CO2. So this alveolar volume is so CO2 rich. Like there's so much CO2 because that's the whole point of gas exchange. And this dead space volume, which like comes in after it, it's in the conducting zone. It's still in the bronchus section. Um, and so this is called dead space volume, and it's made up of 150 milliliters. All right? Oops. Okay. Um, okay. Yeah. It's made up of 150 milliliters. So remember this, dead space volume, which is VD, doesn't actually involve any gas exchange, and it's full of like oxygen because it didn't actually exchange anything. And then alveolar volume, it's made up of 350 ml, and it's full of CO2. All right. And so, this is the end result of all of this. The alveolar volume gets pushed up with the dead volume and you exhale it. So that exhale isn't entirely CO2 rich because like a large portion of it didn't actually exchange any kind of gas, right? And that's all you really need to know. And this is just a very, very simplified version of what Dr. Shams just said, except I want you guys to understand that the boxes he used and the numbers he used are kind of confusing because they don't correlate to the exact number that you have, like 350 and 150. It's not exactly, but this is the same thing, like the same thing. Tidal volume goes in, and then there's a portion of it that gets exchanged or ventilated. And then all of this is now ventilated. The alveolar volume, just like whatever gets exchanged, and it comes out. And then this portion is dead space portion. Like this is the portion that never got exchanged to begin with. Now, an important concept to understand, it's not an important concept to understand is that this was all volume. So this is all just like amounts. So let's talk about ventilation. Ventilation is just how often you produce this volume in like each breath over the course of a minute. So if that didn't make sense, I'll explain it right now. So total ventilation just means your tidal volume times how often you breathe in a minute. So let's say I breathe exactly 12 breaths in a minute. So it's just 12 times 500. But you can't say like a large number. You have to turn into liters, right? So 500 times 12 is 6 liters. And just for your information, there's 1,000 milliliters in 1 liter for your information. Okay. And the same thing happens to alveolar ventilation. So alveolar volume, um, this is an important point that the thing is you don't say alveolar volume times frequency of breath. F is frequency of breath, but you don't say alveolar volume times frequency of breath just because you can't specifically calculate it. Now, total ventilation, it's easy, like you can calculate it, it's easy. There's something called a wait, it's spirometry. It's basically when you blow into like a large tube and it can calculate how much breath you can like inhale and exhale. And that basically calculates like tidal volume, right? However, you can't really figure out how much of your alveoli are being properly exchanged or like gas exchange is actually happening, right? Because there could be a large portion of your alveoli that are damaged or just something there's no specific number. But the thing is with dead space is that it's a set number. Like 150 milliliters consistently does not get exchanged, right? So you can say that alveolar ventilation is total, what's it called? Tidal volume minus dead space volume times frequency of breath. So not exactly alveolar ventilation, because they're never going to give you that in a question, because you can never know for certain unless it's worded differently. In dead space ventilation, it's fine. It's a constant, as I said before. So you can just do dead space volume times frequency of breath. And I put this like this trash can because it's just how much got wasted. Because this is wasted breath, right? Large portion of that didn't even like help. I'm joking. But anyways, this is the equation that I said in specific. This is tidal volume, dead space volume, plus alveolar volume. Both of these combined equal tidal volume. And this is all of this times the frequency of breath. And these are just the separate equations just to keep them in the back of your head. Okay, question now. Let's practice. A 30-year-old man breathes 14 times per minute with a tidal volume of 500 milliliter and dead space of 150 milliliter. What is his alveolar ventilation? I'll give you a second to solve this. Okay. So the answer is 4.9. Why? Because as we said before, we can just plug in the values 500 minus 150 and then times 14. And that just ends up with 4.9 liters. Okay, next. So we talked about air and how it moves and like where it goes. And now we're going to talk about the microscopic details I told you about in the beginning. Let's talk about some basics. Now, these are a bunch of people, and let's say that I put all these people into a tiny little room, right? And so all these people create pressure against the wall. Now, this pressure is called total pressure. All these people are creating total pressure against the walls or in the space that they're containing, right? But you have to remember that it's not they don't walk as a unit, right? There's like individual people, and these individual people like are pushing their own pressure against the wall. And so this would be called partial pressure. Each of these people are contributing to a total pressure, okay? Now we have to remember that all these people aren't the same people. Maybe they're from different places, maybe they have different ethnical backgrounds. So they're colored kind of differently. And this is called the fraction of all the people. So this is a different fraction. So the blue ones are clearly a smaller fraction than the pink ones. Now this is applied to gas. Oh, got you there. We're not talking about people, we're talking about gas. Now, gas creates a pressure in the space that it's in. And, air I'm talking about air right now. Air isn't just air, right? It's made up of lots of components. And it's made up of oxygen, carbon dioxide, nitrogen, and water vapor. And each of these have a specific fraction, like I said before. And wait, okay. Each of them have a specific fraction, like I said before. And all of these airs, or all of these like all of these components of air make a total pressure. So around me is a pressure, and it's hitting on me. And this is the pressure that it, yeah, total pressure. Okay, and so each of these, what's it called, components of air are called partial pressure. And so the partial pressure of oxygen, is a specific amount in the room, or like, yeah, it's a fraction. It's 21% in the room, just like we said here, just like we said before. And it's important to remember that fractions of gases do not change, no matter where I am. It does not matter. It does not matter whether I'm like in the smallest container ever or if I'm literally in the biggest container ever. I don't know what kind of um, comparison that is, but just remember fractions do not change, okay? This is a set number. And yeah, and so gas exerts its pressure, exerts its force differently in the alveoli. And it's just split into a bunch of things. So more specific, we're talking about oxygen, obviously, and CO2, because the rest aren't really that important or necessary for, our alveolar ventilation. So I'll be focusing on that. Now, our arterial blood is just what's it called? The partial pressure of oxygen in the arterial blood, which is like oxygenated. And it's just how much has been dissolved so it can go to the rest of the body and supply the rest of the tissues. And this is the amount of CO2 that was also dissolved. It's usually like less. You're not supposed to have CO2 dissolved. It's not the function. You're supposed to have it like brought back up and exhaled. So it would be like a small amount, but there is an amount of CO2 roaming in the blood just for pH purposes, for, general purposes. Okay, now there's alveolar gas, and it's just how much is it exerting on the alveoli. Yeah. And partial pressure of alveolar oxygen is just how much available before it gets exchanged, right? So what's the point if you're measuring it after it gets exchanged? It's before. And then CO2 is after it gets exchanged from the blood because like there's no CO2, you don't inhale CO2. You swap it out for oxygen. So this is just remember this. Oxygen before it gets exchanged and then CO2 after, because that's when it's relevant. Inspired air is just how much you breathe in, and you're not supposed to breathe in CO2, so you're not supposed to have, a partial pressure of CO2 unless you're in a CO2, like a dense CO2 environment, which is not great. Okay. Expired air, same thing, how much oxygen is in your expired air, how much CO2 is in your expired air, and then venous blood, how much O2 is in your venous blood, and then CO2. Usually CO2 should be more yeah, because it's deoxygenated blood. Okay, so now let's talk about something called Bohr's equation. Now, Bohr's equation, I don't know how to say his name, but it mainly focuses on calculating something called physiological dead space. Now, we talked about something called dead space before, but that was anatomical. Now, all the people on this earth right now currently have anatomical dead space. It's a space in their lungs that doesn't actually contribute to gas exchange, right? But some people have physiological dead space, not physiological or pathological dead space, and more specific. Pathological dead space is just when the alveoli have an issue with gas exchange. So it's down here, there's an issue, it's not exchanging gas to its fullest extent. And so physiological dead space is the combination of anatomical and like this kind of pathological down here in the alveoli dead space. And it combines together, and it's to kind of calculate that, you use Bohr's equation. And so let's go back to over here. Let's say I inspired and now I expired. I want to know how much of that was actually dead space, right? And so we break that down. Now, what was this expired air actually made of? It was made up of dead volume, and it was made up of alveolar volume, or more specifically, tidal volume minus dead space volume, right? But this is more of a fraction, right? So technically, since it's dead volume, there's a large, most of the quantity is inspired air. So I started off with inspired air, and there's a large quantity right over here that never actually got exchanged. So technically, you would call it the fraction of inspired air because there's no CO2 in it, right? And then the fraction that actually got exchanged is called alveolar fraction. And then all of this together is just called expiration fraction, right? And so if you want to calculate how much oxygen, since these are percentages, just remember that fractions are percentages. You want to know how much in specific, how much oxygen you got from each and every single compartment. So what you do is, oh, this is just for your information, everything I just said. But what you do is you times the fraction. So if this was maybe like 0.35 or like 35%, you would do 35% times the dead space volume, okay? And you would get the amount of oxygen. And if you combine all of this, like we know before, we know that VE, which is expiration ventilate total expiration vent total ventilation, is equal to the ventilated dead space plus the ventilated alveolar space, right? And this is just what it looks like all together. Now, if you were to simplify this equation down to like the really simplified version, then it would kind of look like this. Unfortunately, oxygen is not really something, it's not a clear quantity you can use to plug into these equations. It's very variable. It's hard to track. So just think about it. Like I'm breathing in, I'm breathing out, and there's oxygen in every single breath, and it's really hard to keep track of what went where and what was the underlying mechanism of, this oxygen transport. So what physicians use, they use CO2 to measure the dead space volume. Why? Because do we inspire CO2? No, we don't inspire CO2, we inspire oxygen. And so what they have done is they've canceled this entire fraction right over here, right? You don't even need it. And now you can understand fully how much the dead space has contributed to the total ventilation, right? And so, boom, big X on these. And so when you want to calculate Bohr's equation, you essentially use these. Now, and by the way, like a partial pressure of alveoli and expiration, all these are interchangeable just because they're just interchangeable. The fractions and pressures of things are interchangeable unless you're comparing between like uh two different kinds of atmospheres, which I'll talk about right now. But don't get yourself confused. In all honesty, I don't think they're going to make you kind it's good to understand this concept, but in all honesty, I don't think they're going to ask you on this. So it's just good to understand. Okay, so now that we talked about, remember when we talked about like all the air in the atmosphere is made up of tinier airs, like partial pressures? This is basically what Dalton's law says. So Dalton's law just means that like each individual pressure combines together to form a total pressure. Very simple, right? Okay, I'll give you a scenario. You're sitting down at the beach and you're kind of enjoying your time and you're looking at the waves and you're like, wow, it's such a good time to be alive. Now, boom, a gigantic anvil of all the air in the atmosphere comes crashing on your head, right? And this is called atmospheric pressure. So, this is what this poor soul just experienced. And right now, for my exact time and place, the same thing is happening to me. Total atmospheric pressure is pushing down on me. And that total atmospheric pressure has a specific number. At sea, what's it called? At sea level. At sea level, it's 760 it's 760. Okay, that's very important to remember because at sea level, it's always going to remain the same, right? And so Dalton's law also explains that atmospheric pressure, which is PB, equals to all the pressures combined. So oxygen, nitrogen, carbon dioxide, and water vapor, right? So all of this together is just called atmospheric pressure. So this is everything I just explained, but it's good to note that when it comes to alveolar ventilation in pulmonary physiology, you don't want to look at the gases plus water vapor because water vapor doesn't really have a part in uh, gas exchange. So what we usually do is we minus water vapor, which has a set value of 47 from the total atmospheric pressure. That's all you need to know. Because going forward, whenever there's going to be a question or anything like that, they want you to calculate for dry gases, not for every single atmospheric gas in the world. Okay. Okay, so oh, this is supposed to say ideal gas law. I don't know why it says idea, but ideal gas law just means when you want to calculate a specific partial pressure. Now, honestly, none of this is important. What is important is if you want to calculate the partial pressure of one specific gas, this is the equation you use. Px equals the fraction of the gas you're talking about times the atmospheric pressure minus the water vapor. That's so important. Do not miss that. Do not forget to minus this. They never want to ask you about water vapor plus gases. They want to ask you about dry gases because that's what's relevant to you. And I'll plug in some values over here. What's most important, what's commonly asked is the partial pressure of inspired oxygen. So how much of my oxygen is actually reaching my alveoli. And so this would be O2, so oxygen, and this would be equal to 0.21. As I said before, 21% of the air is full of oxygen. And so 21% is 0.21. So anytime they ask you about oxygen, just turn it from 21% to 0.21. This is such an important what's it called? This is such an important value that you need to remember. Okay. So we're not always at seaside level, right? We're not always like on the ground, not on the ground, but we're not always like at the level of the sea. Sometimes we go up. And so as we go up, the atmospheric pressure goes down. And why does that happen? It's very simple. It's just as you go up, you have less air to hit you on the head, right? So if you're over here, there's less air hitting you than if you're down here. There's so much air. And so as you go up, your atmospheric pressure goes down. So it's 700, 600, 500, 400, 300, 200, right? And as your atmospheric pressure goes down, it's going to affect your partial pressure and the way it interacts in your alveoli in a very specific way. I'll tell you right now. Okay, so let's say we have this guy, his name is John. Now, John is climbing this super tall mountain, and now he's at an atmospheric pressure of 347. Now, what John begins to realize is that he's kind of dizzy. And so the random physician, me, who's on the mountain with him for some reason and isn't affected at all, needs to kind of like see how much air is really getting to his lungs, how much air is really getting to his alveoli. I need to calculate his inspired oxygen. So if you want, you can take a second to kind of apply this rule. As I said to you before, if you remember, I'm just going to sit here for a second so you can calculate it. Hmm. Okay, so what's happening here is that his inspired oxygen is equal to the fraction of oxygen times the atmospheric pressure, which is 347, minus pH2O, which is 47. So what's happening is that you have to do 0.21 times 347 minus 47, which is just 0.21 times 300. And that equals 63. And that is really bad because this is the normal range. Now, John, um, he has suffered a fate of falling on the mountain. That is how you apply this very, very, very important formula. Honestly, if you could take anything away from this lecture, it would be this formula. It's so important. It's going to be asked. Just keep this in mind. Okay. Now, let's explain just general ventilation. I've explained a lot of things, so this will make a lot of sense, inshallah. So as you inspire air, it goes down to your alveoli, and this is just in the case if you had no gas exchange, right? So you inspire air and it's going back up, and it's the exact same amount that's being expired. So inspired equals expired, and there's no CO2 involved because there's no metabolic waste being. Okay, so this is talking about ventilation, and the ventilation here is just explaining how much oxygen is inside of the alveolus right over here. And this just depends on how much like oxygen you breathe in, so inspired, and also the amount of CO2 in the alveoli as you're doing all of this. And an important coefficient over here, or an important variable over here, is the respiratory exchange ratio, which we talked about previously. And all this is saying is that if there's an equal amount of oxygen input to CO2 output, it's going to be one. And so if it's one, then this doesn't really matter. And it's just inspired oxygen minus the amount of CO2 inside of the alveolus. And if it's less than one, which it usually is, it's not pathological to be less than one. It's pretty normal, it's fine. But it just depends on like the context and the state. So not every single person that has less than one respiratory exchange ratio is malnourished. I'm referring to the example I put in the beginning. It was just a fun fact to understand how it fits into the whole scope of the lecture. But yeah, this is how you calculate the alveolar partial pressure of oxygen. Now, what if you want to calculate the alveolar partial pressure of CO2? And this is basically after it's been exchanged, right? And so how do you know this? So there's a metabolic component of CO2 that gets dumped into the alveolus, and there's also ventilated alveolar ventilation. And so how much is getting exchanged and how much is going back up. And just to understand the partial pressure of CO2 over here, you have to understand how it goes in and goes out. And that's just how you calculate it. We're just trying to figure out how much CO2 is actually in your lungs. And this is all for, medical assessments to see your pulmonary functions are intact and you're ventilating properly. So yeah. So partial pressure of alveolar CO2, once again, it's just it's just a combined effort of it's a ratio between how much you're dumping in to how much you're getting out. And this is just a solid coefficient that makes all the numbers make sense. So it doesn't really necessarily mean anything. So I don't want to confuse you by saying it actually means something. It doesn't for now, for right now. I mean, I don't know if it means anything. So okay, so this is an application that we can do together. Now, there's this guy, he's right there. He kind of looks really cool, and he has a depressed brainstem. And when I say depressed brainstem, it means that his brainstem isn't functioning. And as you may not know, brainstem is kind of important for your breathing. It controls most of your breathing or all of your breathing. And so if it's depressed, then its functions aren't really working. And so you would say that your alveolar ventilation isn't proper, right? You don't have enough um, of the physiology to really ventilate or like inspire and kind of like exchange gas correctly. However, his metabolic function is normal. So all his cells are doing the job that they need to do and they're dumping the CO2 back into the blood vessels so they can get exchanged for oxygen and the cycle can continue. Okay, so we need to understand what is this guy's alveolar CO2 like? Is he actually getting rid of all the CO2 that he accumulates in his body? We have to understand if his lungs are even doing its job. So if you guys want to, I'm gonna stop here, and if you want to apply the example or the equation that I put over here, here's a here's a little trick or a hint. Okay, so this is how you apply it. So if you want to know the partial pressure of the alveolar CO2, you just put 225 over 2,225, and this just equals 0.1, and then 0.1 times 863, and then this is very low. 86.3 is very low for PaCO2. And so you know that, he's not really ventilating properly. There's probably an accumulation of CO2, for example. And yeah. Okay. Oh, yeah. Wait, hold on. Oh, and if you rearrange the values, you can figure out his alveolar ventilation, like how much he's actually ventilating. So here's another way. Besides doing like, as we said before, total ventilation minus dead space ventilation. This is another way to do it. So this is basically everything I said in kind of diagram format, but just to go over it, let's think of me taking a quiet breath. So not me going like me breathing deeply. This is just me every single day. I'm taking a normal breath. I don't really think about it. This is a quiet breath. And as I, breathe in and breathe out, I'm getting rid of CO2. I'm exhaling CO2 and I'm taking O2 into my body, right? And so ideally, I'd like to have less CO2 in my alveolar space than O2. I want more O2 so it can diffuse properly and so CO2 can get out quickly, right? And so as I keep breathing and breathing, there's going to hit a point where this is called normal ventilation here. Normal ventilation. Now I'm ventilating properly. I'm exchanging O2 at the same rate as CO2. Everything's going great. This is normal ventilation. And at this point, CO2 is approximately 40, consistently 40, okay? This is normal ventilation. And yeah, this is normal ventilation. All of my metabolic needs and respiratory needs are getting met. However, there's a certain point where, let's say I'm hyperventilating. I'm taking long, deep breaths and I'm exhaling a lot of CO2. So I'm going like, this is hyperventilation, and this is consistently, like a lot. And the issue here is that CO2 drops below 40. So here is normal ventilation, and I'm dropping below 40, right? And the issue here is that I'm losing a gradient. I'm blowing off I'm blowing off CO2 faster than my tissues can dump CO2 into the bloodstream. So there's an imbalance here. There's a metabolic imbalance here. I have less CO2 in my body than before. And this is under circumstances like anxiety, metabolic acidosis, aspirin toxicity, all of these. But all you need to know from here is hyperventilation is just me blowing off more CO2 than making it. So generally, I'm going to have when it comes to arterial blood pressure in my blood volume, I'm going to have less CO2 than usual, than normal ventilation. Okay, now, the opposite to that is hypoventilation. And hypoventilation means that I'm taking very shallow breaths. Now, let's say من غير شر, I can't move my lungs, I can't move my diaphragm that well, right? So I can't ventilate that well. So, unfortunately, there's going to be an accumulation of CO2 and it's going to rise above 40. So, above 40, CO2 is hypoventilation because there's an accumulation of CO2 within the arterial blood blood gases, and I'm not exhaling it as well or efficiently as I should be. And this happens in brainstem depression. So, like we said before, the guy, he had problems ventilating. He can't inspire, he can't properly breathe, right? Drug overdose, neuromuscular weakness. This happens generally like more of an anatomical thing where you physically cannot breathe or airway obstruction, unless something is physically obstructing your airway and you can't release the CO2, so there's a buildup. Okay, so let's recap in case I lost you. So there's normal ventilation. Under normal circumstances, you're breathing in and out. The metabolic needs and functions are being met. And then there's hyperventilation. I'm ventilating so much that I'm releasing so much CO2, and now there's not an adequate amount of CO2 inside of my arterial blood, right? It's less than 40. 40 is a very important number, so keep in mind. And then there's hypoventilation, which I'm not breathing enough. And so what's happening is that CO2 is getting trapped inside of my lungs, and there's an accumulation of it, and so it rises above 40. These are so important. Okay, now we're done with alveolar ventilation, alhamdulillah. Now we're gonna do a couple of practice questions and go to gas exchange. First of all, what is the inspired um, partial pressure of oxygen of a person at elevation with a barometric pressure of 247? I'll give you a second to solve this. Okay, so the answer is 42. And this is just, under normal circumstances, the fraction of oxygen, as we said before, times the barometric pressure minus the water pressure. And this is all that happens. And according to this, it's 42. Okay. A patient hypoventilates after surgery. His arterial PCO2 rises from 40 to 55. Which of the following caused this? I'll give you a second. Okay, the answer is decreased alveolar ventilation. Now his PCO2 is going up. So that means he is not ventilating properly. He's not exhaling CO2 as he's supposed to. So what happens is that he has decreased alveolar ventilation, increased alveolar CO2, and it gets trapped inside. Now, increased CO2 production doesn't make sense because you don't increase CO2 production when you hypoventilate. What happens is just there's an inability to exhale the CO2. Increased tidal volume, you're not exhaling more, you're actually exhaling less. So it's hypoventilate, you're not ventilating properly. So this is not even like, this is not even correlated, to be honest. And then hyperventilation, this is the exact opposite of what we just talked about. So I hope that makes sense. Okay, which of the following patients is hyperventilating? I'll give you a second. The answer is B. And when you think about ventilation, this is so important. I keep on repeating this because it's such an important concept. It's really easy. These are free marks. All it depends on is the number 40, right? So look at it. All of these are either 40 or above. So what is the only thing that's letting off more CO2? It's 30, less CO2, right? You're exhaling more CO2, so you have less CO2 in your arterial blood gas, okay? Now, this is kind of long. Two climbers reached the summit of Mount Everest at the same time. One climber breathes 60% of supplemented oxygen, and one breathes no supplemented oxygen. Now, both of them, okay, okay, they're at the peak. Okay, I'm just gonna let you, I'm just gonna let you answer this. Okay, so the answer is C, and this just means all this is asking is like at the barometric pressure, which is 250 because they're at the peak. They're not on the bottom. This is maybe a trick. Maybe they want you to do, um, yeah, maybe they want you to do barometric pressure to be 760, but it was a trick. They just supplemented all of this. And when they talk about supplemented oxygen, when people go up to Mount Everest, they bring oxygen with them because they know that they don't have they're not going to inspire as much as oxygen as they want, right? And so you can't, to increase your chances of not like fainting at the summit or like dying, غير شر, you have to get oxygen with you. So this climber that had O2 was smart because now look at him. He has an inspired partial pressure of oxygen, like triple the amount that doesn't have. And at the summit of Mount Everest, the fraction of oxygen is still the same. It's 21%. And so it's not really helping his situation that he has like no help of oxygen in the air. Anyways, okay, now we're going to talk about exchange. Now, this is a very easy concept, but there's something called the air-blood barrier. And the air-blood barrier is just what your oxygen goes through to properly diffuse into the plasma or attach to hemoglobin. And in this case, it's oxygen attaching to hemoglobin to be transported to the rest of the body, right? And so it goes through 6 layers. It goes to the alveolar epithelium, tissue interstitium, capillary endothelium, plasma layer, RBC membrane. Oh, it says membrane, but it's membrane. And then RBC cytoplasm inside right over here. And so our little O2 guy, our little oxygen guy, kind of has this like suitcase ready to transport himself all the way to the RBC through these 6 layers. And this is just a picture of what that looks like. Okay, so to understand diffusion in general, how did this guy get from there to there? Now, diffusion, Fick's law, this is Fick's law. It's basically the rate of gas diffusion. So how fast can you diffuse from one place to another, like this? And what it depends on is these are these components. Diffusing capacity. Diffusing capacity, I'll talk about it right now, but it's just how well something can diffuse based on the circumstances it's been given. And then there's driving force or like pressure between two things, right? And so what we know from diffusion is that you diffuse from areas of high concentration to low, right? You never go low to high. So the pressure has to be higher here and lower here to drive the force. And that's what makes this up in this whole equation, okay? So diffusion capacity is so important. It's made up of these four characteristics. There's diffusion coefficient, solubility, area. So area of like how much what you're working with, and then thickness, how thick it is. Now, what's important to remember is that area is directly proportional to diffusion capacity. So the ability to diffuse is directly proportional to how much area you have. If you have less area, you're not going to diffuse as well because you don't have enough place. Like, where are you supposed to diffuse? But thickness is indirectly proportional to diffusion capacity because it's a fraction. And so it makes sense. It's logical. The thicker something is, the harder it is to diffuse through it, right? And so you'd want it to be pretty thin. So the less thick it is, the better. And the more, the harder it is to diffuse. Okay. So the interesting thing is that CO2 can diffuse 20 times better than oxygen, 20 times. It's because it has one of the characteristics, solubility. It's 20 times more soluble than oxygen. And so CO2 never has an issue of like a diffusion issue. It's practically always capable to like diffuse anywhere it wants at whatever it wants under whatever circumstances because it's just so much better than oxygen. If only we breathed in CO2. Anyways. Um, okay, so we're going to talk about a different equation. Now, we want to focus mostly on diffusion capacity. And this is basically this equation if it was just like flipped and like reversed. But it's diffusion capacity over rate of diffusion over driving force, which is just alveolar pressure over capillary pressure, because this is exactly where we're going to work right now. Okay, so if we wanted to test diffusion capacity, I just told you that like diffusion capacity isn't really that well measured with oxygen, right? Because the thing is with oxygen is that it doesn't stay consistent, right? It changes. The deoxygenated blood that comes in to the alveoli is 40. Like there's 40 molecules of oxygen. And then at the end, it gets reoxygenated and it has 100. And it's not really that stable and it's not really that consistent and it's not really that easy to measure. So we don't use it. We use CO. Why do we use carbon monoxide? The thing about carbon monoxide is that it gets taken up so quickly by the carbon monoxide has a really high binding potential for hemoglobin. It binds so well to hemoglobin. So the pressure between here and here doesn't even exist because the entirety of carbon monoxide that you inhale will immediately bind to hemoglobin, right? And so it's really great to test the diffusion capacity because if your carbon monoxide isn't um, carbon monoxide level in the blood is not the same amount that you inhaled, then there's an issue, right? There's an issue somewhere in the alveoli, whether it's in the alveoli, whether it's in like maybe an obstructive pathway in your respiratory system, but it's a really good measure of diffusing capacity. Just remember that. Okay. So, what actually affects diffusing capacity? So, when we exercise, what happens is something called recruitment and distension. Recruitment just means you're recruiting more blood vessels and distending it. So, there's more blood volume, which means that it improves diffusion capacity because there's more blood volume. And then there's body position. When you lay supine, once again, all your all your blood vessels kind of like have the same blood volume and they kind of mush in together, so it makes it easier to diffuse through the blood vessels. And then there's body size. It's logic. The bigger your lung size, the more surface area you have, the more diffusion capacity you have. Now, these are all characteristics that we talked about before. So, what are some pathological factors that affect diffusion, right? So, let's just pretend like this is an alveoli. It's kind of ugly, but whatever. Let's pretend this is an alveoli and this is the bloodstream, right? There's so much blood in the alveoli, everything's perfect and everything's normal. However, there's one pathological factor that can affect diffusion is thickness. So, if your alveoli is fibrosing. So fibrosing means that it's just scarring over and it's becoming thicker and thicker. Then, as we said before, thickness is such an important factor that can determine diffusion capacity. And so the thicker something is, the harder it is to get through that thing, right? And so this affects it negatively. Another factor is reduced surface area. Let's say that your alveoli are collapsing. There's a lot of pulmonary diseases that could result in this. Or let's say your alveoli are just dying. So you don't have enough surface area anyways. Therefore, your diffusion capacity obviously goes down, as we said before. Here's a little equation to just remind you. Lastly, let's say you don't even have enough blood volume, then your diffusion capacity will definitely go down. Just because what are you supposed to diffuse if you have no blood volume to begin with? And an example of all of these like pathological factors are COPD, so obstructive pulmonary disorders, fibrosis, as I said before, pulmonary edema, just liquid in your um, lungs, and pneumonia, an infection of the lungs. So it makes it harder, or like the surface area decreases and makes it harder because there's like inflammation going on. Now, you don't need to know these in specific at all, actually. This is just to keep in mind that there are some pathological states at which the lung cannot um, diffuse properly. Okay, so I'm going to explain a concept using a little analogy that I made. Now I'm going to explain O2 uptake. Let's pretend that these students are RBCs or red blood cells. Now this O2 is paper, and alveoli is the teacher. Now, your alveoli has a bunch of oxygen, and this oxygen is just being distributed to all of these red blood cells as they move forward. Now, they're moving at an appropriate pace, and there's an appropriate amount of them, right? And so each of them are getting their papers and they're leaving. Each of them are getting their papers and they're leaving. And yeah. Now, if this teacher gave all of these students or all these red blood cells oxygen, now they would all be filled up and they would reach an equilibrium with her, right? She gave all of her oxygen out and they have all the oxygen. So they've reached an equilibrium and there's no difference between alveolar and capillary um, partial pressure of oxygen. And this is called perfusion limitation. I'm going to explain what this means, but this is the rate of the RBCs getting perfused by oxygen. That's all this means, okay? Now, this is exactly what I said, but in like picture form. So the mixed venous blood, which is the deoxygenated blood, comes, and what drives it is the fact that it has no oxygen. So it's yeah, it goes up and up and up, and it gets saturated with oxygen, and it reaches an equilibrium with the alveolar partial pressure of oxygen, and it stops. It stops exchanging anything because it's reached an equilibrium. Okay, so to understand perfusion limitation, you have to understand that there's two kinds of limitations. There's the limitation based on the actual membrane of the alveolus, and there's a limitation based on how quickly the blood passes by, right? So perfusion limitation refers to how quickly blood passes by or how much of it stays there so it can be, exchanged with gases, okay? So here, this kind of diagram explains mostly everything. So this is the alveolar partial pressure of oxygen. And at this time, this is like the unit of time. And transient time here is what I was talking about. It's like how fast blood goes by, right? So when you're exercising, which is what this line is for, blood goes by significantly faster than when you're just resting, right? And so this is what this is explaining right here. Gas exchange happens normally, and then it becomes at an equilibrium. So there's no longer any kind of gas exchange that can happen unless you add more blood volume and you increase perfusion, which is what the whole point is. That the only thing that limits this kind of gas exchange is perfusion. And an example of this is nitrous oxide. Now, nitrous oxide gets, what's it called? It gets uptaken by the plasma so quickly, it diffuses into plasma so quickly, it reaches an equilibrium so quickly. And the only way to have more nitrous oxide be uptaken, because it reaches an equilibrium so fast, like it matches the alveolar partial pressure so quickly, is to add more blood volume so that there can be more space for it to diffuse. Because the issue here isn't with any kind of like the membrane isn't the issue here. The membrane is that there's not enough blood volume, right? And so if you put more blood volume, it won't be a limitation, like it'll just perfuse. But this is the only limitation of the so-called perfusion limitation, like this whole idea is that some gases, the only thing that stops them is that there's not enough perfusion happening. Okay? Now there's something called diffusion limitation. And now diffusion limitation just means that remember the teacher that we talked about? She was like giving out papers. Let's say this teacher was shoved behind a door, and this door had such a small opening. The diffusion limitation here is that there's something physically wrong with the membrane or physically wrong with the diffusion capacity. So either it's too thick, or there's not enough surface area, or everything that we talked about before for it to affect diffusion. And so what we can see here is that if there's an issue with diffusion, the oxygen will not come to equilibrium with the alveolar partial pressure, right? It will never come. It'll kind of like go parallel, but it's never going to reach it. So there was not no effective, but not efficient gas exchange happening. And as we said before, CO2 is it has like times 20 diffusion uh times 20 solubility times 20 in comparison to oxygen. And so it doesn't face this diffusion problem. And so it's cool like that. It doesn't face this problem. Anyways, so this is just a wrap up of everything I said. So normal diffusion under exercise, it still diffuses properly. Like there's still gas exchange, it still comes to an equilibrium. Don't worry, everything's okay. And at rest, it most definitely does. But the thing over here is when the diffusion capacity becomes lower, and so you have any kind of thickness, small surface area, everything we talked about before that causes low diffusion capacity, this can highly affect your diffusion limitation. So your diffusion limitation when it comes to exercising, so your blood vessels are kind of, not your blood vessel, but your blood is running past your alveoli faster, and so it's not even being, it's not uptaking any kind of oxygen correctly. And on top of that, it has a difficulty diffusing the oxygen correctly. And so there's a humongous diffusion limitation over here in comparison to rest, which is still bad, but not as bad as when you're exercising and also have some sort of diffusion problem. Okay. Now, an important example of this is carbon monoxide. Carbon monoxide, the thing about carbon monoxide is that it doesn't create any kind of partial pressure on the in the blood, right? Because it's uptaken by hemoglobin. It has such a high affinity, and affinity just means like like binding strength to hemoglobin that hemoglobin immediately snatches the carbon monoxide up and takes it with it in the bloodstream, and so none of it even gets to exert its force on the surrounding blood vessel, and so it creates no partial pressure. And the thing about carbon monoxide is that since it's not like a perfusion problem, the thing is that it has a diffusion problem. Like if there's something physically stopping carbon monoxide from coming in, or binding to hemoglobin, then this is how you can measure it. And so if you have an increased amount of carbon monoxide in the alveolar space, you know that it's not getting taken up. So you know that it's a diffusion problem, not a perfusion problem, because once again, it's not a problem with perfusion because it has such a strong like connection to hemoglobin that like perfusion isn't even an issue because it's so strong and so fast. Okay. So low alveolar PO2 or hypoxia. This just means like under all circumstances, when you don't have enough oxygen or you're not intaking enough oxygen, even if you have normal diffusion capacity, you're not going to reach equilibrium. Well, you will when you're like under rest, but let's say you're exercising, you're not going to reach equilibrium. But as we said before, in normal diffusion capacity, you will always reach equilibrium whether or not you're exercising. So this is just something to keep note of. Okay, we're finally done. Wow. Okay, so we're going to do some practice questions and then we'll finally be done. Now, a subject inhales a small amount of carbon monoxide for a diffusion test. And this is just the rate of CO uptake and the PaCO2. I'll give you a second to remember the equation that I was talking about, and maybe you can apply this. Okay, so the answer is 10, just because we talked about like diffusion capacity when it comes to alveolar, partial pressure of alveolar CO2 and the metabolic CO2. This is just the equation that we used. Okay. Oops. Okay. Now, a patient inhales nitrous oxide. Um, its alveolar and capillary partial pressure equalizes within zero point 0.1 second. What limits its transfer into blood? Okay, and the answer is perfusion rate. Now, remember nitrous oxide, the only limitation it had was perfusion. Remember that. Nitrous oxide has a perfusion limitation, and carbon monoxide has a diffusion limitation. This is so important to remember. Okay, that's it. Alhamdulillah, I hope you benefited. Please do not hesitate to reach out with any questions. This is a very I would say it's difficult to wrap your head around. I emphasize a lot on all the things you need to understand and all the things you need to know. Not every single thing Dr. Shem says is important, I promise you guys. I learned from trial and error, all of us did. But, good luck. Inshallah, your exam goes really well. CVP, I was going to say CO too, but CVP is such a nice block, such a refreshing block, so interesting, and it just gets better, in my opinion. I just finished CVP I would say like a month ago. Okay, I'm just talking. But good luck, guys. I wish you all the best. Make sure to fill out feedback if I could improve on anything, because this is definitely something I feel like I could have improved in many ways. But yeah, I hope you have a great rest of your day and goodbye.